welcome back to my channel. My name is Gia. I'm your friendly family nurse practitioner. I'm excited today to talk to you about chronic low back pain. So I'm hoping that by the end of this presentation, you feel a little bit better when a patient comes into you for chronic low back pain. Alright, so let's start. So what are the common causes of low back pain? These are chronic low back pain. Alright, so chronic low back pain is considered as back pain for more than 3 months. So the common cause is going to be radiculitis, SI joint dysfunction, trauma, trochanteric bursitis, and this trochanteric bursitis can present as lateral hip pain, piriformis syndrome, osteoporosis, osteoarthritis, pars interarticularis fracture, ankylosing spondylitis, epidural abscess, malignancy, mets to the bone can cause pain, and also around the area that compressing the area can also cause the pain. Varicella zoster, so the post-herpetic neuralgia, and abdominal aortic aneurysm. So the abdominal aortic aneurysm symptom is severe. It's like a sudden, intense pain in the abdomen that radiates to the back, and it's described as whipping, tearing pain, and this is an emergency. Okay, so alarming features or symptoms. So you want to assess this, or on your history and physical, make sure to look for this abnormal gait, bowel and bladder incontinence, acute urinary retention, bilateral sciatica, IV drug use, history of malignancy, if the pain is worse with supine, saddle anesthesia, progressive neurological symptoms, and recent infection. So this should raise your antenna for a little bit more concerning cause of the chronic low back pain. And so if you have these alarming features, make sure to order an imaging, either CT or MRI, and refer the patient to neurosurgery. You don't want to delay treatment. Okay, so if there's a fever or concern for infection, you want to make sure to order an urgent imaging, again CT or MRI, add in CBC with differential, CRP and ESR, CMP, and consider TB testing too, depending upon the risk factors, and refer your patient to neurosurgery if positive. Okay, for a surgery. If there's no alarming symptoms or features or no fever, so you are going to recommend pharmacotherapy. So topical or oral NSAIDs, skeletal muscle relaxants, like I mentioned earlier or in my previous video, antidepressants. I've seen duloxetine ordered, TCAs like amitriptyline or triptyline 2 for pain, and anticonvulsants like topiramate. Okay, your non-pharmacotherapy is going to include structured exercise, multidisciplinary rehab, weight loss if indicated. If the patient is overweight or obese, you want to recommend weight loss, acupuncture, massage, spinal manipulation therapy, progressive relaxation, cognitive behavioral therapy, and stress management. Okay, consider surgical or psychiatric referral or pain management if pain is persistent or if no improvement. You're gonna have these patients, initially coming into you for acute low back pain, and once you notice that the pain is transitioning to more chronic, then you are going to make sure to refer the patients, because they have to learn how to live with this pain, and they're probably going to live with it for a longer period of time. So you want to prepare them, and so refer them to pain management. Okay, all right, so If there is history of trauma, patient had fallen, has osteoporosis or risk factors for osteoporosis like chronic steroid use, or they've been on chemotherapy or medications that cause bone erosions or bone demineralization. So you want to order x-ray because you want to check the integrity of the bone or any fracture, and refer your patient to neurosurgery if positive. But if it's negative, you're gonna refer to pharmacotherapy and a non-pharmacotherapies that we already mentioned earlier. So pharmacotherapy here, your topical or oral NSAID, muscle relaxer, antidepressants, anticonvulsants. And a non-pharmacotherapy, like I mentioned, structured exercise, physical therapy, weight loss, if indicated, acupuncture, massage, stress management. Okay. Alright, so if your patient has no risk factors for fracture, no need for imaging or x-ray. But I do want to mention, if your patient came into you initially for acute low back pain and you've already recommended the pharmacotherapy, non-pharmacotherapy here as listed here, and they come back to you with persistent pain, I would consider x-ray. All right. And so, like I mentioned, pharmacotherapy, topical or oral NSAIDs, skeletal muscle relaxers, antidepressant like duloxetine, TCAs, anticonvulsants, and non-pharmacotherapy like structured exercise or physical therapy, weight loss if indicated, acupuncture, massage, spinal manipulation therapy, stress management. Okay. All right. And so I hope that this video is helpful to you, or you found it helpful. Remember, like I mentioned, this is just a review, a touch up of what you have already learned from school, and this video is just to present to you what are the things that you can do and refer to when your patient come in, because I know we only have 15-20 minutes for the visit, and my goal is to give this reference to you to start your process when you have a patient coming into you for chronic low back pain. And remember, I'm your friend and your mentor. If you have a diagnosis, a symptom, or condition that you want me to review with you, then you can leave it in the comment section. And hope to see you again. Bye for now.